Я сейчас хочу с большим уважением и почтением предоставить слово нашему коллегу Эрику Кракауэру, его доцент кафедры глобального здравоохранения. Идите к нам уже. Доцент кафедры глобального здравоохранения и социальной медицины Гарвардской медицинской школы, медицинский специалист по паллиативной помощи штаб-квартиры Всемирной Организации ВОЗ, Массачусетс, США, паллиативная помощь, глобальная потребность, отсутствие доступа в странах с низким и средним уровнем дохода, деятельность ВОЗ и других организаций по преодолению этого неравенства. Спасибо вам.
It's okay, I can just use this one. Fall off. Actually, I don't need this one because I have this. I'm going to. It's okay, I don't need. Yeah, thanks. Okay. So, Dr. Kobzev, Dr. Vergazova, Dr. Yurasova, Dr. Nevzorova, distinguished chief specialists in palliative care and colleagues. Thank you for inviting me to your fourth annual Congress of the Association of Palliative Care Professionals and the Vera Hospice Funds Network. It's a great honor for me to be here, and I congratulate you on your fourth annual conference. I would like to begin with an apology. I'm a foreigner. This is only my second time in the Russian Federation, and so my knowledge of the country, of your country, is very little. I was here in March at the invitation of WHO, and I learned as much as I could in a short time, and we made some recommendations after a very brief visit. But for this talk, I've been asked to talk about global access to palliative care and about recommendations for resolving the very large disparity in access to palliative care between rich Western countries and low and middle income countries. And these recommendations are from WHO, where I worked for the past year, and who invited me to this meeting, for which I'm very grateful, and from a commission of the British-based medical journal Lancet, which has had a commission on global access to pain control and palliative care for the last 3 years, and just published its report last month. How long do I have until? 40 minutes. Okay. So I'll go quickly. Okay. And I also apologize that I can't speak Russian. I have to speak English. I apologize for that. So I always like to begin. Let's see. I'd like to begin with a patient. This was a patient I saw recently in Vietnam with end-stage cirrhosis and hepatocellular carcinoma, who was being seen by a member of a home care team from the cancer center in Ho Chi Minh City. And in the background, you can see the family member, the patient's daughter, because it's not only the patient who's suffering, but also the family, and palliative care attends to both. I have no disclosures, no funding from drug companies. Task for the next now 38 minutes is to, as I mentioned, discuss the global agreements that palliative care is imperative for all patients with serious or complex illnesses. And I want to emphasize that, as Dr. Nevzorova mentioned, palliative care is not just for the dying. Also, I want to describe the barriers to access to palliative care by patients in low and middle income countries, and then discuss the recommendations from WHO and from the Lancet Commission. And specifically, I want to emphasize that these recommendations are designed not only to improve outcomes of patients, but also to reduce cost, reduce the financial burden for patients families, to present evidence that palliative care that includes home care can reduce the cost for healthcare systems, reduce the cost for ministries of health of patients with serious and complex illnesses, mainly by reducing hospital admissions, because patients can get care in the community, and promoting universal health coverage, which is the main goal of the new Director General of WHO, Dr. Tedros. You know the definition of palliative care, and Dr. Nevzorova just reviewed it, so I won't repeat it, other than to mention what I think is the most crucial part of the definition, which is that palliative care prevents and relieves suffering. And suffering is not only among the dying. Certainly pain is the most common cause of health-related suffering. And according to WHO, and I think probably all of us would agree, that preventing and relieving it are two of the most important tasks of palliative care. And this requires an opioid. And the simplest, the cheapest, and opioid, and the one that's as effective as any other, is morphine. Oral, immediate release morphine is the most basic, the most essential of palliative medicines. There's been a lot of difficulty in finding the best way to measure the accessibility of palliative care. And there's not really good indicators yet. There's a lot of work on this topic. But for now, one of the best indicators of the accessibility and quality of palliative care is access to morphine, or to any opioid, but especially to oral immediate release morphine and injectable morphine. The most important document that calls for this access is from 1961. It was signed by the Soviet Union and recognized by the Russian Federation. And it states, among other things, that medical use Whoops. What am I doing here? Yeah. Medical use of narcotic drugs continues to be indispensable for relief of pain and suffering. Adequate provision must be made to ensure availability of narcotic drugs for such purposes. And the principle is balance. There must be efforts to maximize the availability of opioids for medical uses while minimizing the risk of abuse and diversion, especially in countries like the United States, like Russia, like Vietnam, like so many, where there is a lot of illicit use of opioids. So yes, there must be efforts to minimize the illicit use and the diversion of prescription opioids to a black market, but this should not inhibit, this should not prevent the use of opioids, the accessibility of morphine and other opioids by any patient in need. That's the principle. And this is the document from 1961. So, how accessible is morphine and how accessible are opioids now in low and middle income countries? Well, it's an enormous problem. It's really a global moral failure so far. So 83% of the world's 7 billion people live in low and middle income countries. That's almost 6 billion people, including 5.5 million cancer patients who die every year in those countries. But in those countries consume only 9% of the world's morphine. Russia is classified, the Russian Federation is classified by the World Bank as a high middle income country. So Russia is included among middle income countries. This is a graphic of the same data. So in countries where 91% of the world's population, where 83% of the world's population lives, in low and middle income countries, they consume only 9% of the world's morphine. Rich countries with 17% of the world's population consume 91% of the world's opioids. Basically, people in rich Western countries get pain relief and poorer people do not. It's a massive injustice. So what about the trends? This is the latest data from the International Narcotics Control Board in Vienna, which is a United Nations organization, and it issues to every country a permit for how much opioid they are allowed to either produce or import based on their estimate. And one can see in this diagram that the use of opioids is going up or has been trending upward in the United States, which is the purple, in Germany, which is the green here, in France. And what about in Russia, which is the blue, increasing, and this only goes through 2015, and I think things are changing a lot. But the increase has not been much. And in other low-income countries, India, China, they're all here. So the increase in the global mean is really based on the high-income countries where the use is going up. As Dr. Nevzorova mentioned, there's a fear of opioids. There's a widespread fear among political and healthcare leaders. So the result is highly restrictive laws and regulations, which I see that Russia is changing very rapidly, but are still a problem, and I hear that there's still a problem in educating the healthcare and leaders around the country about the new, very progressive regulations in the Russian Federation. Doctors are afraid of being punished or even arrested for using opioids. Training is not yet adequate. The opioids often are still not available. Nurses are sometimes afraid to give them. I'm not speaking just of Russian Federation, all over the developing world. And even patients are afraid of them. Sometimes patients refuse them. Prescribing regulations for prescriptions are often basically make it impossible. So this is a prescription from Vietnam, where I work a lot, from a few years ago. A doctor, to write a prescription, had to write the prescription, sign it, then get a signature and a stamp from her hospital director, and a signature and a stamp from an anesthesiologist, while trying to see 50 patients in one morning. So essentially that means no one, this is probably the only prescription that was ever written that got all of those signatures and stamps. It just didn't happen, which meant the patient suffers. And this leads to a vicious circle. So there's low consumption, and therefore every year when the Ministry of Health has to report to the International Narcotic Control Board their estimate of how much they need for the next year, they base that on the previous year's consumption, so it's a very low estimate. So the International Narcotics Board approves that, because they approve almost any estimate, but that means that there's not much opioid allocated to that country, there's not much opioid produced or imported, so there's low consumption and the cycle just continues. And this is the result. Patients in terrible pain unnecessarily, because it's very treatable. In 95% of cases, the pain can be relieved. Patients who are very sick and very vulnerable, and we don't take care of them. We allow them to suffer. And another result, as you know well, not only in Russian Federation, it's been reported here, but it happens everywhere. Patients commit suicide. The very beginning of the Lancet Commission report mentions a case in India, like with Admiral Apanasenko from a few years ago. Suicides because patients cannot have access to pain relief. And it's not, again, it's not only the patient. So in the note left by Admiral Apanasenko, he mentioned that he was willing to endure the suffering, but he could not endure watching his family watch him suffer. And he wanted to end their suffering as much as his own. And the risk to doctors, from a case from several years ago. Dr. Koriniak, also well publicized, arrested for trying to relieve cancer pain. So when I came to the Russian Federation last March, I was, how could I say? In English we would say, it took my breath away. The advances, the rapidity of change, of improvement of the regulatory climate for pain relief and palliative care in the Russian Federation, I've never seen before. I've worked in Asia, in Africa, in Europe. I've never seen such rapid change. This is remarkable progress, as was mentioned in the previous talks. Oops. In particular, the Executive Order 1403 on improvement of access to narcotic drugs. This is extremely important. Without these policies, palliative care cannot develop. So I salute all those who have advocated for this, and the Ministry of Health and the Russian Parliament for making these rapid changes. And I think this promises to to result in a lot of relief of unnecessary suffering. I also heard about, thank you. I also heard about the existence of training programs. For example, at the Sechenov, First Moscow State Medical University, the intermediate level training that Dr. Nevzorova is leading. We met many of the committed palliative care leaders from around the Russian Federation. I was able to visit some exemplary clinical services, the first Moscow hospice and also the hospice in Krasnogorsk, near Moscow. And we heard that funding is now provided for palliative care for all 85 regions, if I recall correctly. These are remarkable and very, very impressive changes. I think this is an excellent basis for further development of palliative care. And we need to write about this. We really need to write about even these developments, because other countries need to see what the Russian Federation is doing, and other countries need to see that very rapid progress is possible where there is the advocacy and the political will. This is very important to be known globally. So that's the good news. And it's very exciting. But there's still a lot of work to do. So again, these are the most recent data from the International Narcotics Control Board. I just looked a few days ago. And this shows the opioid consumption in morphine equivalent. So it's not just morphine, it's all opioids converted to the equivalent doses of morphine. And we see that there was a slight change in the early 2000s in Russia. Russia is the orange. And in the last, these are all, these are the different medications in Russia. So the total just shot up in 2014, 2015, and I suspect this is related to the new laws and regulations. Morphine, however, morphine consumption is flat. Fentanyl shot up, and the total shot up because the fentanyl increased in the last 2014, 2015. But morphine consumption was very flat. So still a lot of work to do. I suspect that in the last 2 years, probably if we had that data, we would see an increase. But that data isn't available yet. This map is from the Lancet Commission report. And at the bottom is the link. This report is available online. And perhaps if we have everyone's email address, we could either send them these slides or at least send them the link to the Lancet Commission report. We're working on getting it translated into Russian. This map, in this map, the size of the country is based on the morphine consumption in milligrams of patients who have serious health-related suffering. Serious health-related suffering it means that they have a condition that requires palliative care, essentially. Not only cancer, there's 20 different conditions that we identified. So in Canada, for patients with serious health-related suffering, during the course of their illness, they consume, on average, 68,000 milligrams of morphine. United States, 55,000 milligrams. So these are patients with cancer, particularly cancer, but also vascular disease, heart disease, kidney disease, liver disease, whatever it is. In Western Europe, 18,000 per patient during the course of their illness. Russian Federation, 124 milligrams, compared to 68,000 in Canada. China, 314 milligrams. India, 43 milligrams. So still you see the huge difference in opioid use between the rich Western countries and all others. So still a lot of work to do. So now I would like to just mention the recommendations and the suggestions of two different bodies. The World Health Organization, for which I worked for the past year and for whom I'm now a consultant, and the Lancet Commission. So for the United Nations and the World Health Organization, there are various documents that mention that access to opioids and to palliative care are essential. I won't go into detail there, although I will say this document is translated, this top document is translated into Russian. It's available in Russian. Also in Russian is the World Health Assembly resolution of 2014. So how many of you are familiar with this document? How many have seen it and read it? So just a few, not so many. Okay, so we should maybe spend a little bit of time. How am I doing on time? 10 minutes or?
20 minutes.
I have 20 minutes, okay. Lots of time, okay. So first I should mention, when the World Health Assembly that issued this resolution, that is the governing body of WHO. It is the meeting every May in Geneva of all ministers of health of the world. Once a year in May, all ministers of health of the world come together. That's the World Health Assembly, and they decide what will be the work of the WHO. And when they issue a resolution, that becomes the work of WHO. So in 2014, they issued this resolution, 6719. And it said that palliative care is a component of comprehensive care for people with any serious or complex illness. It should be integrated into comprehensive care. Palliative care should not be separate from disease treatment. It should be integrated with prevention, diagnosis, and treatment. And many patients who are getting curative care should also be getting palliative care. And Dr. Nevzorova mentioned this, and I want to give some examples of how palliative care can even improve cure. So for example, patients with a very, very toxic chemotherapy regimen for cancer, if the side effects of the treatment are very well relieved, the vomiting, the neuropathic pain, the fatigue, the patient is more likely to be able to continue their chemotherapy and maybe have a better chance for cure. Similar with drug-resistant tuberculosis. The treatment for multi-drug resistant tuberculosis has many severe side effects. If patients, if the side effects are very well relieved, and if the social supports that Dr. Nevzorova mentioned are provided, patients have a better chance of continuing and completing their treatment and being cured. So yes, palliative care can even contribute to cure. And now, almost 7 years ago, there was also a big study from my hospital in Boston that randomized cancer patients with metastatic non-small cell lung cancer, to receive immediately a palliative care consultation at the time of diagnosis of metastatic disease, or usual care. And usual care usually meant they got chemotherapy, and then palliative care consultation was only requested at the discretion of the oncologist. The intervention group The patients also got usual care, but they got palliative care assessment immediately, and my palliative care team saw them at least once per month. The patients randomized to early palliative care not only had better quality of life and less depression, they lived 3 months longer than the other group, than the usual care group. So palliative care, at least for patients with metastatic non-small cell lung cancer, live longer. And why exactly that is, research is still working on. So anyway, back to the WHO resolution, palliative care should be integrated into disease treatment, even sometimes into curative treatment. And it's necessary for universal health coverage. It should be accessible throughout the life course. And Dr. Nevzorova mentioned the importance of pediatric palliative care. What about babies who are born very prematurely and probably won't survive? Now, in countries throughout the world, there is no palliative care in the neonatal intensive care unit. Babies are put on ventilators, even it's very clear they're going to die, they're getting stuck with needles. There's efforts to save their lives even when it's clearly not possible. Babies with severe congenital anomalies who will not survive. Palliative care is needed from the beginning of life to the end of life. Palliative care and access to essential medicines, including opioids, is a human right. It's part of the right to the enjoyment of the highest attainable standard of health and well-being, which is in the WHO Constitution, again signed by all countries, including the Soviet Union and recognized by the Russian Federation. Palliative care is an ethical responsibility of health systems. It's not an option. It's not something you can do if you have a little bit of money left over. It's an ethical responsibility of health systems. All the ministers of health of the world agreed to that, and the Russian Federation is showing how that can be done, how this can be made real very quickly. It's a duty of all healthcare professionals to alleviate pain and suffering. There will never be enough specialists to do all of the palliative care in a huge country like the Russian Federation. The primary care doctors, the feldsher, the nurses, the specialists in oncology and in cardiology and in many fields, all of them need to have basic training in palliative care. It's especially important for those who work in the communities, who do primary care. So the family doctors, the feldsher, to have basic training in palliative care. I already mentioned the importance of assuring access to opioids and assuring that efforts to minimize illegal use of opioids do not prevent access to opioid pain relief for patients in need. There has to be adequate training, there has to be adequate funding. So at the end of the document, the World Health Assembly urged the member states to implement palliative care policies across all levels with emphasis on primary care. And again, I don't think any country that I know of has done so quickly, more quickly than the Russian Federation. There needs to be training of at least 3 levels. So basic training needs to be integrated into the standard required education of doctors and feldsher and nurses, and probably also social workers and pharmacists. For healthcare workers who routinely work with patients who need palliative care, so oncologists, hematologists, neurologists, cardiologists, should have intermediate level training, like the training now provided at Sechenov First Moscow State Medical University, 144 hours. That would be considered intermediate level training. And there should be specialist training. So I'm very interested in the efforts to create the first specialist training program in Russian for Russian Federation and the Russian-speaking world, so that eventually every region in the Russian Federation and all of the CIS states, the Community of Independent States, can have specialists in palliative care to teach palliative care in the medical schools, to implement the programs, and to advise the health departments in all the regions and all the countries. WHO is making some efforts to implement this resolution. So around this time last year, the WHO issued a planning and implementation guide for palliative care for program managers. And WHO has to follow certain regulations about translations. They have to get the translation certified. But I believe, because of the great energy of Dr. Nevzorova and colleagues, has it already been translated? But just not officially yet. So I believe that it's been, we'll try to get the WHO to officially approve it. That's the next step. But it's a very useful guide. And I personally think it's very helpful, and it may be of interest to the chief specialists from the regions. Right now, even on the plane trip from Boston to Moscow yesterday, and on my way back on Friday, I'm working on 3 more guides. One on integrating palliative care into primary care, one on integrating palliative care into pediatrics, and one on integrating palliative care into responses to humanitarian emergencies and crises like earthquakes and severe storms and armed conflict and infectious disease epidemics. There is an online community of practice that anyone is welcome to join, and my colleague at WHO, Isabelle Huguet, can be contacted. She doesn't speak Russian, she speaks French and English. Possibly of interest, there's a project to develop mobile, palliative care mobile system where patients and community health workers have a cell phone to communicate with doctors and nurses at community health centers. So I was the medical officer for palliative care until 2 months ago. There are several collaborating centers, and one of the projects that I hope to discuss on this trip is to develop over the next couple of years a WHO collaborating center here in Moscow in association with a specialist training program. Okay, the last topic is the recommendations of the Lancet Commission, which were just published 2 years ago. This was our first meeting in New York, seems like a long time ago. And to try to be very brief, our first goal was to try to estimate more scientifically the global burden of health-related suffering. The current estimation of need for palliative care is not very exact, and we tried to do it a little more carefully by identifying the disease conditions that most commonly generate a need for palliative care, and then estimating the types and prevalence and duration of suffering from each of those conditions. So, for example, what are the specific types of suffering caused by cancer? Well, could be physical suffering like pain and dyspnea and nausea, psychological suffering like anxiety and depression and delirium, social suffering like poverty, and with some diseases, stigmatization, like with HIV/AIDS or tuberculosis, and spiritual suffering. Why is God doing this to me? Loss of meaning. Then, based on those estimates, and by the way, our estimate was around, I think 60 million people per year in the world. Based on those estimates, we created a basic or essential package of palliative care to alleviate most of that health-related suffering. It includes the interventions, medicines, equipment, social supports, and human resources. And the social supports generated a lot of discussion for reasons that have been mentioned, which basically means that ministries of health do not typically provide the social supports. They usually come from another ministry, but yet the Lancet Commission felt this needs to be included in the package of palliative care, even if the funding doesn't come from the Ministry of Health, because so many people suffer for social reasons, from extreme poverty in particular. This just lists the 20 conditions that we identified. I'm sorry it's impossible to read. It includes all the usual ones such as cancer and heart disease and kidney disease and liver disease, but I want to mention a few others. Hemorrhagic fevers like Ebola. It's hard to imagine suffering more intense than that suffered by patients with Ebola in West Africa. Tuberculosis, especially people with drug-resistant tuberculosis undergoing extremely toxic regimens for a long time, for 2 years or more. And those whose treatment is unsuccessful, who then are dying but may not die for months or years and are just waiting to die and have a life-threatening infection, so have to be isolated to some extent. Also, low birth weight and premature infants, infants with congenital malformations, and also people with injuries. All over the world, in emergency departments and in surgical wards, there's patients with severe injuries who are getting no analgesia. Post-operative pain is also woefully inadequate in many places. And where the idea of the Lancet Commission is wherever pain relief is inadequate, even if it's acute pain from a femur fracture or from crush injury from an earthquake or from post-operative pain, wherever the pain relief is inadequate, people with training in palliative care cannot ignore that. These are the interventions. They're based on the distinctions between various kinds of suffering. So prevention and relief of physical suffering, psychological suffering, social suffering, and spiritual suffering. The medicines. So the medicines that the Lancet Commission chose are based on the WHO model list of essential medicines, but it's a bit smaller. It's a bit different. It's based on that list. We chose the medicines that are necessary to relieve the specific symptoms and types of suffering that are most common in patients with serious or complex illnesses, that are safe to prescribe and administer by people with basic training in palliative care, and that offer the best balance of accessibility, clinical effectiveness, safety, low cost. These are the medicines, and again, it's a long list, but I want to just point out a few of them. Dr. Nevzorova mentioned antipsychotic medicines. So any physician with basic training in palliative care should be able to assess and treat simple anxiety disorders and depression, which are very common in people with many kinds of severe illnesses. So they should be able to prescribe a selective serotonin reuptake inhibitor like fluoxetine or any of the any of the others, which are available in the Russian Federation. And delirium is a very common problem in patients, especially near the end of life. So haloperidol, let's see, where's haloperidol? Ibuprofen. Where's haloperidol? Is it this?
Yes. Все верно. Okay.
Yes? Galoperidol. So this antipsychotic drug is useful not only for treating delirium, it's very useful for some types of common types of nausea, and it's also very useful for treating anxiety in patients who are at risk for delirium. So very older patients, very sick patients who may develop delirium. If you give benzodiazepine, haloperidol is useful for anxiety. Any doctor with basic training in palliative care can prescribe these. Now, as you may know, in the US, there's a big problem with overdoses of opioid medicines. And there's also a lot of illegal opioid use, not only in the US, but in Russian Federation. So the solutions are that we need to be very careful about following the rules for prescribing, careful both to prevent illicit use and also to make sure our patients have access, but also that opioid use disorder, which is a mental illness, according to WHO, and research shows that it's best dealt with as a mental illness, that treatment should be available. So this bottom right picture shows a patient receiving methadone as a treatment for opioid use disorder, and there are many and methadone or buprenorphine maintenance therapy has been shown by far to be the best treatment for opioid use disorder. It prevents criminality, it prevents transmission of HIV, and prevents recidivism, returning to use of illicit opioids. And most importantly, it also prevents death from use of illicit opioids. The equipment in the basic package is very inexpensive, easy to use, pressure-reducing mattresses. Some of this, the Lancet Commission had to come up with a package for all countries, and our concern was especially the poorest countries. So many of this equipment is easily available, is readily available in Russian Federation. I would emphasize the importance of opioid lock boxes, but from what I've seen in Russian Federation, you're very careful with locking the opioids already. The social supports, again, maybe not from the Ministry of Health, but need to come from another ministry or from somewhere. For the very poor, money for rent so they don't lose their housing, allow the children to go to school, make sure that the patient's family has food. Sometimes in the very poorest countries, they need blankets, sleeping mats, shoes, soap, the very essential things, transportation to get to the hospital or the clinic, and funeral costs. A big problem in some countries is that bodies are abandoned in the hospital because the families are too poor to pay for a funeral. The human resources and which exact human resources at which level of the healthcare system depends on the healthcare system. The key is the competency, the ability to prescribe opioids and all medicines to make sure they're accessible, even for the rural poor and those who live in very remote areas, for example, in Siberia. The Lancet Commission did a little bit of study of the cost of palliative care, and we looked at the cost of this package, of administering this entire package for all of the patients in need in that country, based on our criteria. and we chose one low-income country, one low-middle-income, the low-income country was Rwanda, one low-middle-income country, which was Vietnam, and one high-middle-income country, which was Mexico. So the country that's most similar to the Russian Federation is Mexico. And in that country, we found that the cost of the entire package, including the cost of the salaries of the healthcare staff, the medicines, the equipment, the social supports, everything, was 0.5% of the annual healthcare budget and less than 1% of the public healthcare expenditure. Actually, I'm sorry, I think this does not include the social supports, but for all other parts. So it's less than 1% of the healthcare budget. It's very cheap. Palliative care is very cheap. And perhaps most importantly for the Ministry of Finance, there's a lot of data from high-income countries and from two high-middle-income countries like Russia, Romania, and South Africa. It's been shown that palliative care that includes home care can save money. It reduces the expenditure for patients near the end of life by reducing the need to return to the hospital and reducing the length of stay in the hospital. Patients are not afraid to go home, and many problems, if the pain gets worse, if the patient starts vomiting or bleeding or whatever, that can be handled in the community, often in the home, where the patients prefer to be, without having to return to the city. So it saves money for the healthcare system, it saves money for the patient, and ministers of health don't have to decide, well, if we put money into palliative care, then we have to reduce the funding for childhood vaccinations or maternal health or cancer. No, there can be more money for those other programs. And this has been shown in countries of the same economic status as Russia. So the final recommendations of the Lancet Commission are these. Relieving suffering is an imperative, and most people in low and middle income countries don't have access yet. An essential package of palliative care can relieve a large proportion of this burden of suffering, and the package can be made universally available. Social supports and the basic package in general can improve the welfare of the poor at a modest cost, and it can contribute to universal health coverage. Prevention of non-medical use of opioids should not prevent the medical use and the accessibility for relief of pain. And policies, as I said, policies are required to make sure palliative care is accessible. So those are the recommendations. I can stop there, or we could stop there or talk about the recommendations from the last visit.
Okay, спасибо. Уважаемые коллеги, спасибо, Эрик. Да? Спасибо, Эрик, огромное.
Спасибо.
Удивительный анализ и удивительный подход, да, к основным вопросам, к основным проблемам оказания паллиативной помощи. У нас есть еще изменения, начиная с февраля месяца. У нас есть новые данные, которые мы тоже передавали Эрику и Елене Дмитриевне. Еще мне хотелось бы отметить, что сейчас и в последнее время на территории Российской Федерации ведется работа по разным направлениям, но мне хотелось бы отметить об образовании. Очень важно, что сейчас было сказано, и мне хотелось бы сделать немножечко пометку и важное замечание о том, что на территории Российской Федерации существует не один цикл по паллиативной помощи на базе Первого медицинского университета. Сейчас только в Москве их 4. но кафедра и первый курс по паллиативной помощи был сделан на базе 3-го медицинского университета, стоматологического университета. Это важно. Важно сейчас, что Российский университет дружбы народов делает курс по паллиативной помощи, что делает 2-й медицинский университет по паллиативной помощи детям курс. Сейчас в стране уже в этом году мы видим 43 цикла по паллиативной помощи, которые делаются в разных вузах страны, образовывая врачей. К сожалению, не все циклы достаточно, учитывая, что они только начали работать, не все из них в правильном направлении, с хорошим количеством часов. Есть некоторые циклы по 16-18 часов, по 32 часа, по 36, вернее, часов. Почему? Потому что у нас в законодательстве не регламентировано, какое количество часов должно быть. И, соответственно, эти короткие курсы вроде как дают нам право уже работать. Да? И сейчас при анализе мы понимаем, что циклы по всей стране в течение года появились, но какой уровень образования? И поэтому крайне важно то, что сейчас принимается профессиональный стандарт врача паллиативной медицинской помощи, который разработала Национальная палата с участием Ассоциации российской паллиативной медицины. И мне хотелось бы отметить, что следующий шаг – это примерные образовательные программы, которые утверждаются Министерством здравоохранения Российской Федерации для того, чтобы именно в их рамках, по их плану работали все циклы в стране. То есть вот действительно процесс идет и развивается буквально с каждым днем. Спасибо вам огромное. Уважаемые коллеги, мне хотелось бы сказать, что мы сейчас должны с вами уйти на 15-минутный перерыв. Дать возможность вам немножечко выдохнуть, но только не больше 15 минут, пожалуйста. И дальше мы с вами встречаемся здесь. У нас изменения в программе. К сожалению, у нас нет специалиста. Галина Корчагина не будет сегодня нам по объективным причинам, и поэтому мы немножечко сдвинули доклады. А сейчас, через 15 минут, мы очень активно используем Эрика и его значит, доброе отношение с тем, чтобы будет буквально через 15 минут мастер-класс по лечению одышки и жизнеподдерживающей терапии у пациентов, онкологических и неонкологических. И параллельно на 3-м этаже в 2 залах будут проходить балентовские группы по психологической поддержке. Там определенная запись должна уже была, заранее на регистрации нужно было записаться. Уважаемые коллеги, кто туда сориентирован, пожалуйста, в 11:45, 3-й этаж, залы Ермолов и Тучков. Кудревицкий Александр Рафаилович, клинический психолог, психотерапевт, психолог фонда «Подари жизнь». И 2-я группа Клепинина Наталья Валерьевна, клинический психолог, научный сотрудник отделения клинической психологии Димы Рогачева института, город Москва. И 15-минутный перерыв. Спасибо вам.